Okay, here we go. Welcome, everyone. My name is Aisha Akhtar. Welcome to the final day of our Health Equity Week here at the Epilepsy Foundation in Greater Chicago as part of an umbrella of National Public Health Week. It's actually the 30th anniversary of National Public Health Week from the APHA, American Public Health Association. Lots of public healthy things here. So welcome to all of you from wherever you are joining us. For those of you who are not familiar with the Epilepsy Foundation, this is just a little bit about our mission and our really intentional DEI statement. You can take a read at that. But we're really excited to have this conversation today. We've had a full week of conversations in different places. We've had workforce development. We had a conversation on epilepsy and advocacy and stigma. We had a conversation yesterday on looking at the social determinants of health of public transit and public spaces. And so that's been really exciting. And today we're going to dive into just kind of big picture. What are the trends that we're seeing for epilepsy, focusing on epilepsy today, and then looking at a smaller model of how we can address the gap in access to care. Also super excited to share this proclamation that we received from the City of Chicago Mayor, announcing that this is Health Equity Week. So this is something that we're super excited about. Here is our team, small but mighty team. Alex Houston is one of our educators. He's actually on a different call right now. And then we have two interns who have been working with us this semester. So that's been a really exciting process to sprinkle the health equity education team around. So today is going to be really great. If I seem informal, it's because I know Brandy and Jenna very, very well. And we are all colleagues in the epilepsy space. And I'm really excited to have both of them have this conversation, looking at just the bigger trends of access to care. So Brandy Fuhrman, she's our EFA's Chief Outcomes Officer. So it's her job to make sure that all of our public health outcomes are all realized and actualized. And she'll be sharing some information today. And then we have Jenna Carter. She is the executive director of Epilepsy Foundation Minnesota. And I have asked her to share a little bit about how she's solving an access to care issue in her state. Jenna is responsible for the entire state of Minnesota, which is not only just a large state, but a large demographic pool. So we'll hear from her about an amazing program that she has. And so with that, I am going to stop sharing my slides and turn it over to Brandy, who will kick us off. So welcome. Thank you, Brandy and Jenna.
Thank you, Aisha. I am going to share my slides and put this hopefully in presentation mode. Okay, are you seeing the full screen?
Yes, I think you might still need to hit the presentation mode icon.
Better?
No, I mean, we can see the slides, but we can see everything.
Okay.
Okay. Yeah.
Let me try again. How about now?
Yeah. Oh, look at the
Excellent.
logo.
Excellent. Great. Thank you so much, Aisha, for inviting me to be part of this conversation. I'm really excited to share from my lens the sort of national approach to improving public health for epilepsy and especially access to care, and then to hear from Jenna how they are taking a more localized approach within their state. So I just wanted to start by grounding us all in a framework that should be very familiar to people in public health. And this is a framework created by the de Beaumont Foundation describing 10 essential public health services. And from the Epilepsy Foundation of America's perspective, when we're thinking about how do we create a nationwide strong public health system for epilepsy, these are the types of skill sets and features that we're trying to support and build. So you'll see in some of my later slides, I'll reference, which of these areas a particular program might best fit. But really, the key is all of these things are important to building a strong public health support system for people with epilepsy and for people with other kinds of chronic diseases. So today, I hope you'll come away from this discussion being able to explain some of the strategies that we've put in place in order to change those systems level issues and hopefully improve access to high quality care for people. So I wanted to share this with you, which is sort of my mental model of what we need to do and have in place for every person living with epilepsy in order to ensure that they have the best opportunity to achieve their optimal outcomes. And that is people need to have access to high quality care. That's a number one necessity. But they also need connection in their community to services that they might need. And the transportation team that you talked with, the other day was a great example of that. People with epilepsy in particular are very reliant on transportation services because when you have seizures, you can't drive. And so, that connection to being able to be uh, able to move and work and live and play in your community with those services is really important. People need to be supported in a safe environment. And that means having folks around them who understand what seizures are, can recognize when seizures are happening, and can respond appropriately. And those are folks like school teachers, like police officers, like first responders, like daycare providers or elderly care providers, support in a safe environment. And then finally, and I think this is one of the most important of the features, is people need to be empowered by both understanding their condition and having the skills to manage their condition when they're outside the healthcare system, right? 90% of our lives are lived outside of the healthcare system. And so we and our families and our loved ones need those skills to be able to manage epilepsy in that community setting. So this, to my mind, is the things that we need to be able to strengthen and ensure that people have access to in order to be able to achieve their best outcomes. Okay, so we know, though, that we are not doing a great job with all of them. And we know that because people are having uncontrolled seizure activity, and it's at a disproportionate number to what we think people should be having if they got their best care. So there have been studies over many years that suggest that with high quality care, a person who is newly diagnosed with epilepsy can achieve seizure control for about 70% of those people can achieve seizure control within the first 1, 2, or 3 drugs, right? If their epilepsy is diagnosed correctly, if they are treated with the correct medication, usually as a first line choice, or if they are quickly referred to more advanced treatment options if those first 2 medications fail. So with that in place, about 70% of people should be able to get seizure control. What publications like this tell us is that 70% is not what we're achieving in the population. These kinds of numbers, having half of all adults with epilepsy still having uncontrolled seizures, means to me that we are not getting people to appropriate high quality epilepsy care. So we know that there's gaps that we need to fulfill. We see that in disparities in remission rates. So for children who develop epilepsy, there is some proportion that are expected to be able to achieve remission. That rate is different across different socioeconomic groups and race and ethnicity groups. And so we know that some of those factors are interfering with a child's ability to achieve seizure remission or epilepsy remission. And that can be an access to care issue. Some of the reasons that we might be seeing these things are things like disparities in being able to be adherent to medication. When we say adherent, we mean being able to take your medication on time as prescribed by your provider. And there are lots of things that can get in the way of medication adherence. Simple forgetting. you and I do this too occasionally, just forget to take the medication you're supposed to be taking. But there are other things that can get in the way. Transportation issues. You can't get to the pharmacy to pick up your medication. It's not something that can be sent in a mail pharmacy situation. So you can't afford the medication. You can't afford the copays. Your insurance won't cover these kinds of brand medications if you're on a particular brand medication versus a generic. So there are all kinds of ways that there can be barriers to medication adherence. And we know that, a seizure can result from a single missed dose of medication. So this is a very serious issue for our community. And we know that there are disparities in being able to be adherent. There are also disparities in people getting access to some more advanced epilepsy therapy, like a neuromodulation device. Those in the epilepsy community are pretty familiar with the vagal nerve stimulator, or VNS. There are disparities across racial and socioeconomic groups in terms of using things like the VNS or the RNS, which is another neurostimulation device. And that can impact someone's ability to become seizure-free. We also know that there are disparities in epilepsy surgery. Surgery can be a very effective treatment for epilepsy for the right candidate, but there are things that get in the way of people being able to be evaluated for surgery. So we know that there are just terrible disparities in access to care. And it can result in really what is the most tragic outcome for epilepsy, which is early death. Early death can happen from a number of different causes, including sudden unexpected death in epilepsy, or SUDEP. It can come from accidents or injuries that result in death. It can come from prolonged seizure activity, or status epilepticus. We also have a higher suicide rate in people with epilepsy. And so all of these things that get in the way of access to care can absolutely result in the worst outcome for people with epilepsy. So there is clearly a need. And so I really wanted to transition now to talking about, how do you approach a population when you know that there are disparities, when you know that there are needs for access to care, and give kudos first to Aisha. Because this is a map of epilepsy-related hospitalizations and emergency department visits within the zip codes in the Chicagoland area. And this is available on the Cook County Health Atlas, only because Aisha was persistent and determined and worked with her local health department to get this data out there and visualized and available to people to begin to see where the disparities in emergency department visits and hospitalization for epilepsy are existing. And you can see there's a pretty wide variation across these different areas of the Chicagoland area. So this gives Aisha and her team, a lens to really focus in on where are the areas of greatest need, the populations of greatest disparity. So Aisha, congratulations. This, I hope we can replicate across other communities across the United States. So our first strategy to really reach that population is an awareness strategy. And I'm just sharing here with you some of the messages that we've developed in an awareness campaign to help people with epilepsy feel recognized, feel more comfortable about sharing their condition, and also, recognize when epilepsy may be something they're experiencing but have not yet been diagnosed. We know many people who are not having the types of convulsive seizures that are often shown on TV or in movies. They're having different seizure types, may not recognize that that's what's going on for them. So awareness of even what seizures are, and then again, how to recognize and respond to them, is an important piece of getting into the community and getting the awareness of epilepsy more quickly disseminated. And it's important that those messages be inclusive and culturally relevant, culturally appropriate. And so you can see what in these these ads, we've been trying to engage Spanish-speaking communities, Black and African American communities, by featuring people from our community, Lowell on one side here and Rachel on the other side, and Manny and his daughter on the top, real people with epilepsy who have been willing to be public and to be champions and advocates, to share their stories so that other people feel free to share theirs as well. My epilepsy journey can often. Okay, and there's video and radio ads as well, but we won't go through those today. Another strategy that we've used, again, to reach into those communities to help improve awareness is to partner with other public health facing groups and professional organizations. So this is just a smattering of a part of our partner group, who has really helped us both expand our awareness campaigns and also expand the opportunity for training for seizure recognition and first aid. So the more folks that we can train in these communities, the more people are available to be a support and to be a help for people with epilepsy. And all of this can contribute to the ability of somebody to be supported to access the care that they need. We've also had a strategy to connect people with direct service to the resources that they might need. And so what I'm showing you here is a snapshot of the types of things that people will call our epilepsy and seizures helpline for. You can see the number one reason people are calling is because they have medical related questions. We also use the helpline as our primary contact line. So a lot of calls about to talk through the organization and get to someone in the organization. But if we go beyond that, we're also seeing calls related to financial assistance and financial assistance programs, calls related to legal questions, discrimination, and what are your rights as a person with epilepsy under the Americans with Disabilities Act and some of the other disability-related legislation. Calls about seizure first aid and getting their community more connected to the training opportunities. So these are ways that we can support individuals and families to get the connections in their community that they need. The other piece to accessing high quality care is making sure that the providers who are providing that care have sufficient expertise to deliver high quality care. And so one of the strategies that we've used at the national level is something called Project Echo. And the idea behind Project Echo is that you are building a faculty group of experts within, in our case, epilepsy. And that expert faculty group is mentoring non-specialist providers who are treating people with epilepsy out in the community. So this might include your family physician. It might include a general pediatrician. It might include an advanced practice nurse or advanced practice provider, who are caring for people with epilepsy and want to be able to get access to the best thinking about how to treat and manage those people with epilepsy. And so that helps extend into the community the level of expertise that really will help people get the high quality, effective care that they need. And then I finally wanted to end with a program that we've developed to try to improve the healthcare system for people with epilepsy. It's one thing to access the system, and there certainly are barriers and gaps to people even getting access to the system. But then once you're there are important elements of supporting somebody with epilepsy that we believe can be improved. So one example is this group of epilepsy centers who are working with us in the epilepsy learning healthcare system are sharing information about how their patients are doing and learning from each other about who has come up with strategies that work well and sharing that with the other groups. One example I have for you is when we first started this work with these centers, we asked, how do you figure out whether somebody's having any problems with adherence, medication adherence? Because we know there are a large number of people who should be able to achieve seizure freedom if they can reliably take the medications that are working for them. And the center said to us, well, we just say, are you having any trouble? And what we learned was when when the physician is merely asking, have you been able to take your medicine? Vast majority of people say yes, no problem. But when you deliver a checklist to them that says, have you had any problems with forgetting your medication, getting to the pharmacy, affording your medication, dealing with side effects, any of these things that can get in the way in terms of adherence, the number of people who say, I have one or more of these barriers goes up tremendously. And so we have started in this learning healthcare system to deploy a standard screen for medication adherence into their regular visit schedule. This is not what they were doing before, but we believe it is helping to pick up people who are having these challenges. And you can see here, it's collectively about 20% of people have one or more of the 17 different barriers that we screened for. That helps the provider narrow in on somebody who is having trouble for one reason or another and can be supported to get over that barrier. So we've also created a toolkit that providers can offer for every one of those 17 barriers that somebody might experience. And they're resources. They are strategies like to help remember to take your medication, things that should be very practical and actionable kinds of things that people can do to get over the barrier that they have. So there are ways, that you can also influence the healthcare system so that when people get to the healthcare system, they're getting the best quality of care that they can. So, and this is just a listing of how many people who have one of those barriers endorsed these particular issues. So, and the last strategy I want to talk about is, building a larger number of skilled public health workforce practitioners. And we've attempted to do that through an annual conference called the Public Health Institute. And the Epilepsy Foundation has sponsored this conference with support from the Centers for Disease Control for the last 4 years. Our theme is building inclusive communities. And what we try to do is make sure that people in the public health community are aware of all of these resources and strategies and have the skills to deploy them in their local communities. So this has been our sort of overall approach to trying to build a nationwide strong public health system for people with epilepsy. And I have to say, it really depends on folks like Jenna and her team to be able to translate some of these things into her local community to support the people with epilepsy in Minnesota with some of these connections and services. And I know she's going to talk to us about a terrific strategy that she's come up with locally. So I just wanted to thank you again for the opportunity and acknowledge the incredible work of all of the people at the Epilepsy Foundation of America who support these programs, but also our partners and our affiliates out across the country who deliver this work. We absolutely would not be touching the number of people that we do without their partnership in local communities. So I want to acknowledge and thank them for that. And of course, all of this work has been supported by a grant from a cooperative agreement from the Centers for Disease Control. And we have tremendous experts and support from our project officers, Renee Freeman, Maggie Moore, and Rosemary Cobau. And so I want to acknowledge them specifically for the incredible support and work that they've done with us to make sure that we're using these funds in the best way possible. So thank you, Aisha. I'm happy to talk through questions in the discussion.
Sure, wonderful. Thank you so much, Brandy. That was such a beautiful overview, and I think it's just going to be a perfect segue to just tee up Jenna. And while you transition to your slide deck, I'll just remind everyone, go ahead and answer or ask any questions in the chat, and we'll definitely have a conversation after Jenna goes through her slides. So thank you.
Let's see if I can also get my slides going in the right way here. Okay. So are you guys seeing the regular presentation, or are you seeing, can you tell me what you're seeing?
I think you still need to hit
Are you saying like, thank you, Aisha?
No, I don't.
Oh, okay. So you are seeing
I still see like for like your file name on the top. You might have to try presenter mode again.
It's always fun, isn't it, Brandy?
Mm,
You gotta, and you'd think after this many years that we would have it totally figured out.
it's all good. It's all good.
Okay, here, let's see. Thank you for your patience, everyone. Um, I think I know what happened here. I think it went into a different
No worries.
screen. All right.
I'm glad, Brandy, you reminded everyone of the integral role of the CDC, because of course, with everything that's kind of happening right now, it's very real. And as we were sharing before everyone came on, like just public health people are, we are MacGyvers, as you said. We will figure a
Yeah,
way.
We improvise, we adapt, and we overcome.
Yes.
we do. Um, okay. Share my screen here. And if this is the way it looks, then it's just going to
That's
be the way it
fine,
looks.
yeah.
Yeah. So I'll go to present. So this must look good now, right? Hopefully.
Yay.
Okay, awesome. Good. Well, thank you, everyone. I am very excited to be here today to talk a little bit about the work that we've been doing in Minnesota. And just want to start by thanking Aisha for the invitation. I always look I always admire the work that you are leading here, Aisha, and or in Chicago, and especially thinking about that map that Brandy showed in her slides. That's exactly what I want to see happen in Minnesota and what we're working toward right now. And so thank you for leading and being the example for the rest of us across the country to do similar work. And thank you, Brandy, for all of the work that you're leading at the national level. We really couldn't do what we do at the affiliate and local level if it weren't for the work that you're doing. And so thank you for leading the way and paving that path for us. So I'm going to talk a little bit. I'll introduce myself. I'm Jenna Carter. I'm the executive director at the Epilepsy Foundation of Minnesota. I have been with the organization since November of 2021. I started by leading the division that does all of our community-facing work and our public policy work. Prior to that, I was working in public health in the Center for Prevention at one of our healthcare companies. And so have been in public health for about 18 years now. And I love it so much. And so I'm excited to be here for National Public Health Week with all of you all who also apparently love public health. So that's great. So a little bit about Minnesota. We are about 5.6 million people now. We have about a quarter of our state are people of color, and about 10% of the people who live in Minnesota are immigrants and refugees. We have about half of our population living in the metro area. And then, of course, the other half living in greater Minnesota. And then across our state, we have about 55,000 people who live with epilepsy, who we are here to serve and have been here since about 1954, when we were founded by a group of doctors who saw the need to have greater support for people who are living with epilepsy across the state. So I'm going to jump into a little bit about what we have been working on. So I'm going to talk a little bit about how we started, where we are now. We are really in the process of our initiative, and then how we're planning to move forward. So I'm going to start with our belief and our approach, which I think is really important. And if you all are public health folks, then you've probably heard of this before. But public health is really about improving the health of your entire population. And so a couple of years ago, EFMN really made a commitment to start taking a greater public health approach in our work. Of course, we are 100% committed to serving individuals on a one-on-one basis, but really starting to think about how can we make a greater difference across the entirety of the population that we serve. And so we know and we believe that to really improve the health of our entire population, we have to really focus on those who have the greatest barriers and the worst outcomes. And I often talk about the curb cut effect, which I first read about it in 2017 in the Stanford Social Innovation Review. It's an article published by Dr. Angela Glover Blackwell. And really the idea is, and research backs this up, is when you design your programs, your policies, when you make decisions with those who have the greatest barriers and challenges at the center of your decision making, that there are oftentimes positive ripple effects for the broader community and society. And so, wheelchairs are a great example. So decades ago, people in wheelchairs began advocating for curb cuts because they wanted greater access to safety and, of course, access to grocery stores and healthcare and all the things that many take for granted being able to access. So finally, I think it was in 1990 that the ADA was signed and curb cuts requirements were put into effect. So now communities across the country are required to build new infrastructure with curb cuts. So people in wheelchairs, people using mobility devices now have greater access. But of course, we have seen ripple effects. There are more positive benefits. So if you are pushing a stroller or a grocery cart, you're pulling your luggage behind you, or you're a worker pushing a cart, you now have the benefit of using a curb cut, and it has made your life a little easier. Other examples are seatbelts. They were initially designed to keep children safe in cars. Of course, we know they have saved hundreds and hundreds of thousands of lives. Telehealth is another great example. It was initially put in place to serve people in rural communities who lived in healthcare deserts. Fast forward post-pandemic, and I bet everybody on this call uses telehealth at some point or another in their lives, whether it's necessary or it's just convenient for you, right? So there have been more positive societal benefits. And so that is really the framework that we bring to our work, that if we can design our events, our programs, our policies with those who have the greatest barriers and the worst outcomes and at the center of our decision making, that we can make greater improvements in the overall health of our community. So I'm so glad that Brandy went through a lot of the disparities that we see within the epilepsy community. So I won't go through too many of these, but I guess the point I wanted to make here is that in general, the epilepsy community in and of itself experiences greater inequities than the general population. So I personally feel, and I don't know if Brandy and Aisha would agree with me, but I actually don't think that the public health community at large has spent enough time focused on people who are living with disabilities, focused on the epilepsy community. And so I just have a couple of kind of high level data points here about the community overall. 29% of adults with epilepsy cannot use a car or use public transit independently. Nearly half live at the income level of 25,000 or below. I know in Minnesota, about 40% of our population are on Medicaid. About 42% of children with epilepsy live in homes at or close to the poverty level. So again, I won't go through all of these bullet points, but the point is that our community in general experiences greater challenges to accessing healthcare and has greater challenges living a healthy and well life. And then again, I know Brandy covered some of the research here, and so I'm not going to go too far into this, but the point is that even within the epilepsy community, we have intersections, right? And we know that low-income individuals and then individuals of color, people from communities of color, do experience greater inequities and worse outcomes in their epilepsy journey. So as you see in this chart from the CDC, Black individuals had the highest age-adjusted death rate for epilepsy between 2005 and 2014. In addition, African Americans are more likely to be diagnosed with epilepsy due to a variety of factors like head injuries or stroke, more likely to experience status epilepticus, which is very dangerous, 60% less likely than non-Hispanic whites to receive surgery, excuse me, and at increased risk for SUDEP, which Brandy described. And so we were looking at the research and we saw what it was telling us. And of course, we 100% believed what it was telling us. And we wanted to talk with our community to better understand what was creating those barriers. We had assumptions about what those things were, but we really wanted to make sure that we were asking our community. And so we did have community listening sessions. And some of the things that we heard were, real and perceived implicit bias in the healthcare system, lack of awareness of care. We often, engage with individuals who don't know, have never heard of an epileptologist, but probably haven't heard of a neurologist either, and have been getting their health care at their community clinic. And so that was a really significant barrier. Lack of culturally appropriate care, discordant beliefs between cultural care, their cultural beliefs and the healthcare system, language barriers, immigration status, and fear of deportation, and then increased likelihood of experiencing other challenges related to social determinants of health, like access to transportation. We've talked about food access, income, housing. So really the bottom line for us was that racial and ethnically diverse communities really experience unique and significant barriers impacting their epilepsy. I'm not going to spend much time on this, but research validates what we found in our community listening sessions. So we just took a step back and we asked ourselves, given what the research is saying, given what our community is telling us, how can EFMN really better support people living with epilepsy who have some of the greatest barriers and some of the worst outcomes? And how can we do it in a long-term and sustainable way? I think, for a variety of reasons, oftentimes lack of resources, organizations will kind of do one-off projects, really trying to make a difference, which, are valuable. But for us, we really wanted to implement a strategy that was a long-term strategy serving the community across Minnesota. So we moved forward with a community health worker strategy. And so community health workers are frontline public health workers who are often from or have deep knowledge of the community being served and supported. They really are I believe they've been kind of the missing link in the healthcare, public health, social service sector. I think we saw that really, really starkly when the pandemic hit, and there were so many barriers and challenges to reaching certain communities, and particularly different racial and ethnic communities. And so, we believe that community health workers really are kind of the solution to making sure that we are engaging more deeply and with a diverser group of people. And then evidence shows that, right? There's plenty of research that shows in different chronic disease states that when community health workers are deployed and deployed effectively, that they can improve health outcomes amongst people who are experiencing the greatest barriers. So over the past couple of years, we have been building this model. For many, many years, EFMN has had outreach managers on staff, but quite frankly, our approach was pretty reactive. So we waited for people to call us. They called in, we would give them a resource, or we would refer them to another organization, provide them some education, and then they would kind of go on their way and then come back whenever they needed something else from us. Now, moving to a community health worker model, we are more intentionally in community, partnering with organizations that are community serving, like FQHC, so federally qualified healthcare centers, community-based organizations like the Mexican Consulate here in Minnesota. We are starting a partnership with Hennepin Health, which is our only county-based healthcare system in Minnesota and the largest serving low-income individuals. Sorry. Oh, excuse me. And so we are really, we're really, really excited. We have been deploying this model. So we now have our outreach managers, our community health workers. We have developed HIPAA compliant systems and processes. And so we did this for a couple big reasons. First, we wanted to make sure that our community knew that we were doing everything possible to protect their private health information. We also have developed reimbursement systems and processes. So in Minnesota, we can bill for the work that we do under state Medicaid. We also have a couple insurance private payers who we can submit for reimbursement. And so, of course, we needed HIPAA compliant systems for that. And then we have developed healthcare referral partnerships. So we have 3 major healthcare providers that we have established formal partnerships with. And then, of course, to do that, we wanted to make sure we had HIPAA compliant systems as well. I will say it's very, very exciting because these healthcare referral partnerships, I feel like we've finally figured it out. And these are actually really challenging to put in place. But in 2024, we had close to 100 people referred to our organization from different epileptologists. And our kind of, I'll call it maybe our follow through rate or our success rate in terms of actually reaching the patient and providing comprehensive support and services to them was about 75-77%. And so I don't, for those of you who have tried to do this work or are doing this work in your areas, these kind of referral partnerships are kind of tough nuts to crack. And so we feel really good about that. And now we are focused on continuing to build that work. The last thing I'll just say with the community health worker strategy is not only are we being more intentional about being out in community, but the personalized support that we provide is much more comprehensive. I mean, some of our community health workers are going to doctor's appointments with people. They're walking through medical forms with them, really supporting them in the moment, but also, as Brandy alluded to, being necessary, really empowering them and giving them the information, the resources, education, and skill building that so that they can continue to do these things on their own as they move into the future. And so I guess I could talk for hours and hours about this, and so I'm going to leave it at that, but I'm happy to answer any questions. So in addition, we deployed a couple other strategies. So we knew that it was not enough to hire some community health workers and expect to do a great job serving diverse communities across our state. We knew that we had to really focus on making sure that our culture and that all individuals working at our organization had the skills to effectively work across difference. And so we, last year, all staff took the Intercultural Competency Development Inventory. It's a mouthful, but really it is a tool to kind of assess and then help you grow in your own individual ability to work across difference. And difference doesn't mean just different racial and ethnic cultures, but all cultural differences, right? Whether it's rural and urban. I mean, we all come from a variety of cultures. And so really just being able to work across all of the differences that we all have. Again, we have been developing referral partnerships, and I'm not going to talk about that again. And then we also have launched a couple other things like a Spanish-speaking Connect group. So our Connect groups are basically social emotional support groups. We have a variety of them that meet monthly virtually, so they're accessible to everybody across the state. So we've launched a Spanish-speaking Connect group that is very, very well attended, very popular amongst the community that we serve. And then we've integrated Spanish language access into our major events. So we have translators and just make sure that our clients who speak Spanish feel welcome and accepted and included in the events that we have. So moving forward, our focus is on sustaining and growing our work. So we have officially started receiving reimbursements from the state and from insurance companies. And so we are continuing to refine that model, making sure that we are being as efficient as we can. We also are going to be adding small group reimbursement. So we can, in the state of Minnesota, be reimbursed for our Connect groups. And we often will have anywhere between 8 and 25 individuals on those in those meetings. And so we are starting to build that model now. And then, of course, this work, and it doesn't matter if it's at EFMN or any other organization that's doing community health work and getting reimbursed, it requires additional funding to sustain the work. And so we will continue to fundraise and look for grant opportunities and to keep this work going, as we would have before this work anyway. We are also really focused on advocacy. Right now, obviously, cuts to Medicaid is a really big deal and a big conversation that's happening. And we are working in coalition in Minnesota to do everything possible to not see cuts to Medicaid. Like I mentioned, about 40% of the population we serve are on Medicaid, and it would be incredibly detrimental if we see massive changes to that program. In addition, we have a bill to make epilepsy a public health priority in Minnesota. So our Minnesota Department of Health has zero resources to do anything around epilepsy, but they're very interested in doing more around epilepsy. So that's great. So we have a bill. We actually just found out we're in the Senate HHS omnibus bill, which is fantastic. It's much further than we thought we'd get in our first year. And what it would do would be to create an epilepsy program at the Minnesota Department of Health, starting with a real focus on data collection, analysis, and sharing, and then using that data to develop a statewide strategy to improve health outcomes amongst the epilepsy population. And so we are very, very excited about that. Send all the good vibes our way, especially considering what's going on at the national level and the CDC. It is unknown whether we will have national surveillance data for the foreseeable future. And so having it at the state level would be very, very helpful and impactful. We are going to continue our intercultural competency building. So every single staff member at EFMN has a plan, a development plan related to building their cultural competency. And so those will continue to move forward. And then we do quarterly all staff trainings as well. And then again, right now we're really focused on building that partnership with Hennepin Health. So for our healthcare referral partnerships, we've really simplified it, and we are able to actually just send a HIPAA compliant link to healthcare providers. They can fill it out, and then that information comes into our organization, and we follow up with the patient. And so Hennepin Health is very excited to work with us. There's, of course, a lot of things to consider because they have a huge patient population, but that is a high priority for us. Another priority is starting to do work with emergency rooms. We often hear from people who have had negative experiences in emergency rooms, negative care. And so we want to make sure that we're working with people in emergency rooms, not only in their understanding of how to treat people with epilepsy, which is kind of shocking that we would have to do that, but also to make sure that they know they can refer them to us to get more additional, resources and support. So with that, I think that's what I have. I have my email address up here in case anybody would like it, jenna.carter@efmn.org. But otherwise, happy to answer any questions that anybody has.
Awesome. Wonderful. Thank you, Jenna. I think that was a really good compliment to both of your conversations. And I just want to commend you for all the hard work you're doing. And I always love hearing all these updates. And since the last time I saw you, you have even more updates that are super exciting. So congrats. I know you work very hard. It's great. So do you have any anecdotal stories, like maybe one or two that you can share about how a community health worker might have followed someone and made the referral? And I would just love to hear something like that.
Yeah. So like I said, previously when I came to EFMN, our approach was kind of more reactive. Like people called us and we would help, and we kind of meet their needs in the moment, and then they would go on. Now, when somebody calls, we have a set of questions that we ask to make sure that we can provide the best support that they are desiring and that they need. And so we have kind of three different pathways. One is kind of more comprehensive personalized support. And so that's kind of probably our more intensive pathway where we would get reimbursed for that work. The second is, maybe they just need kind of a one conversation. We kind of talk through some things with them and then they're good to go. And then the other lane is kind of like, they might say, hey, I need a pamphlet. Right. And we send them the pamphlet and that's it. But we do for everybody, we go through a series of questions to make sure that we understand kind of what their situation is, and that they also, some of them are kind of some reflection questions so that they know that we can help with a variety of other things. And if they're interested, they can go down one of those other paths. And so I would say recently we had a gentleman who was referred to us from FQHC, and he had bounced around from provider to provider, really struggled with medication adherence. And a big challenge was there was a language barrier, and then he was undocumented, and so there was some just fear of sharing things in the medical appointment. And so one of our community health workers who does speak Spanish has been able to work with him. So she actually went to his house. They sat down. They looked at all his paperwork. She helped him schedule an appointment. She went to the appointment with him. And the doctor was like, thank goodness you're here. Like, we have been struggling to figure out how to make sure that he understands, really kind of breaking down those communication barriers and really helping like having our staff Angela in the room, like it helped facilitate some trust. And so the doctor was grateful. He was so grateful. And she is continuing to work with him now just to make sure like he's gotten his medications, he understands how to take them, he understands tools that are available to help him remember to take the medication. And so he was so frustrated. His healthcare providers were frustrated, and so Angela has been able to really help get him in a better place. And so that's probably the most recent example. And prior, our old model, we probably never would have heard from him because we wouldn't have had the referral partnership. And if he had contacted us, we would not have provided that comprehensive of support.
That's incredible.
Yeah. And community health workers in Minnesota, at least, there's programs that you have to go through with some of the community colleges, technical colleges to get your certificate. And they are trained on really how to navigate these situations in a way that really provides support, but also empowers. And they are trained pretty well on just like setting boundaries, right? And really making sure that the work is done in a good, productive way for the person being served and the staff, if that makes sense.
Yeah. Yeah. And here in Illinois, we are in that certification process. So it hasn't officially been certified yet in the sense that we're not able to bill probably till 2027 is what I'm thinking.
That's great.
Yeah, but it's great. It's in the works and it's just such a great, impactful program. And I love that EFA, like we have that CDC, that CHW training program, of course. So that's something that we can start with right away and that we have started with right away already in Chicago. So that's good. Just training existing community health workers. So there is a question in the chat about hurdles that you might have experienced in working with healthcare providers in terms of providing services with community health workers. So it sounds like in the case that you described, having that sort of language concordant healthcare team obviously worked, but what other hurdles have you seen from the providers?
From the provider perspective?
Yeah, it looks, Michelle, if you want to come off mute and ask your question, just so I can.
Sorry, I was also trying to read through some of this.
Yeah. Let's see if she wants to.
Oh, and the partnership development. I think initially some of the challenges were just, I think they were really worried about their patients' privacy and their data. And so the fact that we have gone through the process of making sure that we have HIPAA compliant systems. I mean, we've had lawyers look at all of our stuff, like we feel really good about it. We feel really confident then going to healthcare providers. So initially, we actually did have business associate agreements that we have signed and then MOUs just to make sure that they feel, really confident in partnering with us. I will say now when we approach other healthcare partners who have kind of seen and we can tell them how things are going with the other partners, they're much less hesitant, and we have a HIPAA compliant JOT form. And when we tell them that we're HIPAA compliant and that we've made it super easy, they're pretty excited. I think the second biggest challenge was just like, oh, now you're going to ask us to do something else. We're so busy. We have limited time. Oftentimes these things fall to the nurses or the office, the clinic managers, and they're just like, really, I have so many things going on. But when we say it's literally a link, you click on it, it's short and sweet, sends it to us, and then we follow up with the patient. They are, we've had very little hesitation.
If I can just add to what Jenna said, I think in your model, it sounds like the community health workers are working for EF Minnesota.
Yes.
So I'm familiar with another model that New England has implemented, and that is to embed the community health worker in the epilepsy clinic. And I think there, some of the challenges have been like being able to get credentials at the hospital for those community health workers. It's taken some time, I think, at different places to be able to get that. So it's interesting how the different approaches, are they an EF Minnesota employee coming in with the patient versus are they a hospital employee or volunteer? Ways that we can look at how does it, where do you struggle? But I think that that piece about privacy and respecting people's, ability to choose who has access to their protected health information is really important.
Yeah. The other thing I will add, initially, we left it to the patient to follow up with us. So the doctors gave them the information, and then that was kind of it. And we had zero people contact us. So I feel very strongly that when you implement these type of partnerships, that like we say we follow up with the patient, and we will do 3 tries. If we can't get a hold of them, or they decide they don't want to, we're like, fine, that's great. But it does not, like I said, we had, I think, nearly 100 people referred last year, and almost a 77% success rate in terms of reaching them and going through the process of meeting their needs. And so
that's a really
I
great
wanted to say
success
that
rate.
out loud, because I'm like, don't
Yeah.
bother the other approach.
Okay, so I think we're coming up on time. So before we sign off and we finish out this awesome Health Equity Week, I would love for each of you to share with our audience something impactful they can do in their spaces wherever they're coming from today. Just one thing that we can all do to move the needle. What would you suggest?
Well, I think there's lots of things to suggest, but the very simplest is just get involved. There are so many opportunities to volunteer with your local epilepsy foundation, your national epilepsy foundation, so that you can help spread the word about these supports and services and epilepsy awareness. And we need more people to be part of this army. So lots of ways to get involved, but that, for me, that would be the very first step.
Yeah, I agree. And I feel like right now I mean, it's just such a tough time on so many levels for many people in our community and for the public health workforce in general. Um, but and maybe this is my bias, is like I have so much experience in the policy world where I'm like, get involved in advocacy, now more than ever. I feel like it doesn't have to be partisan, right? Like the issues that we deal with every day in the epilepsy community should not be partisan issues. And I think that sometimes decisions get made, and decision makers don't understand the real impact in the lives of people who live with epilepsy, or any other kind of chronic condition, or whatever is going on. And so when they hear from people who either are living with epilepsy or work closely with people with epilepsy, can share the stories and the real impacts, like I think that makes a huge difference. I mean, we've seen it make a big difference in Minnesota, and again, just now more than ever, I think that it's so important that as many voices as possible speaking up and building awareness, like Brandy said. I think so important.
Yeah, and some of the conversations I've been involved with recently have also just been like lead with the emotion, share stories. If data doesn't work right now, let's share stories and don't forget that human to human element. And I'm with you, Jenna. Get involved with advocacy. That's where things start. Find your local representative, share your story. I think those are really, really easy, low-hanging fruit things that we can all do. Wonderful.
Well,
Well,
thank you again, Aisha.
yeah, thank you so much. Lots of great.
Thank you.
Thank you so much for being here, and I appreciate all the work you're all doing, and we'll stay in touch.
Bye,
Great. Thank
everyone.
you.
Thanks.
Take
Take care,
care.
everybody.
Bye.
Bye.